Well, good evening, everyone, and welcome to the OphthoGenie Oral Board Success webinar. We're so happy that you guys are taking some time out of your night to spend it with us, and we're really excited that you're already starting to think about how to best set yourself up for oral board success. First, we'll introduce ourselves. My name is Kendra Klein. I did my residency and my fellowship training in medical retina at Tufts New England Eye Center in Boston, Massachusetts. I worked in private practice in Phoenix, Arizona for about 3 years and then returned to the East Coast. And now I work at Leahy Clinic, which is just north of Boston, and I'm involved in the clinical training of medical students, residents, and fellows. Nora, do you want to take a minute and introduce yourself?
I'm Nora Mwakisa. I currently live in Denver and practice medical retina and comprehensive and cataract surgery. I trained at Tufts in Boston for residency and fellowship, and then I was on faculty there for a couple years, and then moved out to Denver, and I've been here for about 4 years.
So just briefly, I wanted to take a minute to talk about our oral board experience. So we took it back in 2017. At that time, everything was in person. And we used books. There were no web-based platforms at the time. And we came away feeling like there was definitely something lacking. So one of those things I think would be an appropriate format to really prepare yourself for the unique style of the oral board questioning. Really lacking would be like the ability to develop your cadence of speaking and a way to monitor the timing of your responses. We felt the material was not quite up to date, especially regarding the treatment modalities. And there were no really feedback or self-evaluation tools. Nora and I both did the Osler course, but I think we felt it was a little bit late in the game. It wasn't really enough time to integrate what we learned before we took the exam. So the OphthoGenie really grew out of necessity, and we're going to talk a little bit more about that later. But first, you can advance to the next slide. We wanted to say congratulations. Before jumping into the nitty-gritty of oral boards, I just wanted to take that moment and say congratulations, because by the time you qualify for the oral board exam, you will have completed medical school, internship, an accredited residency, you'll have a valid medical license, and you will have passed the written qualifying exam. So I would say before you look ahead, really look behind and see how much you've already accomplished. And take comfort in the fact that you know most, if not all, of this content tested on the oral board exam. You just need to learn how to demonstrate that knowledge. And that's where we come in. First, though, I wanted to take a minute and just see where everyone was at on their kind of studying journey. If you can, I don't know if you can raise your hand or if there's a way of notating, like if you're taking the exam in October, or if you can just unmute yourself and say who's taking the exam in October.
Or feel free to write in the chat as well.
Oh, yeah.
Yeah, I'm in October.
I'm taking it. Okay. All right.
October.
Yeah,
That's great. Good. So this is very relevant for you guys. Okay. A lot of you guys are taking it in October. Good. So let's go ahead one slide to the outline, and we'll take a look at what we're covering this evening. So we've already told you a little bit about ourselves. Next, we're going to go into some key information as well as the content structure and grading criteria for the exam. Then I'm going to talk about what you can expect on exam day. And that has, changed in the past couple of years now that it's a Zoom format. And then Nora is going to show us some resources and study tips and unique features of OphthoGenie, as we feel it is the ultimate oral board study tool. And then we're going to leave some time for your questions. But along the way as well, please use that chat box if you want to ask a question or raise a hand or chime in. So let's look at some key information. So how fast can you get this process over with? An important question. So candidates who register for the first available exam and pass each one on the first attempt can obtain board certification in as little as 9 months after residency graduation, so within the following year. Registration is completed on the ABO website, and the fee is $1,950. Upon passing the oral exam, one is certified for 10 years. Currently, the oral board has been offered twice yearly in the spring and fall, and the dates for 2024 have not yet been announced. So let's go into the structure and grading. So what's on the test? How is it presented? And importantly, how are you graded? So first we'll go into the format. So I like to stress that this is a clinically focused case-based exam. So you will be presented with patient scenarios, and you basically have to walk the examiner through your diagnosis and management for each case. So very realistic, real life information. There are 6 topic areas that are listed here, and they're paired to constitute 3 testing rooms. So each room has a total of 14 cases, 7 from each topic, so a total of 42 cases for the day. And this is a timed exam. So you have 50 minutes allotted to each room. And over the course of the day, you will meet at least 6 examiners. Let's look at the grading. So the grading remains a somewhat mysterious process, but the ABO does review the grading guidelines on their website. And I encourage you to look at their ABO website and really read through it. There's a lot of information on there. They describe their grading as compensatory, which means if you have stellar performance in one content area, it can compensate for not so stellar performance in another area, as long as overall you meet the performance standard for passing. And the performance standard is described as the ability to completely and appropriately diagnose and manage 42 patients in clinical scenarios, each of which are equally weighted. The standard is not adjusted based on how the other candidates perform. So the ABO reports that although it's statistically unlikely, it is theoretically possible for all candidates to pass the exam, which is great. We want that. And the scoring criteria for each case is broken down into 3 distinct categories. So the first is data acquisition. So this takes into account, did you elicit a relevant history, identify the pertinent findings on the clinical exam, and order appropriate diagnostic testing? Diagnosis. So did you generate an appropriate differential diagnosis and correctly identify the most likely diagnosis? And then management. So did you provide safe and effective management, including any medical or surgical treatments? Did you, if you're talking about surgery, did you talk about the risks, benefits, and alternatives of surgery or treatment? And did you educate the patient and recommend appropriate follow-up? So let's look next at what to expect on exam day. So what to expect on exam day. We've arrived at the day we've been waiting for, the exam day. So we've been preparing for big exams our whole academic careers. And we know that we should start studying early, we should avoid cramming, we should take it easy the day before a big exam. We know that we have to get a good night's sleep and lay out our professional attire and eat a good breakfast on the day of the exam. But this exam is very different from all of the other exams you have taken. All of those things are important with this as well. But in addition, there are some extra considerations that you need to keep in mind because this is a virtual exam. So you need to plan ahead. And again, this is a Zoom format now, since for the past couple of years now, since the pandemic. So make sure you have the most up-to-date version of Zoom on your desktop, and that the Zoom account being used for the test is displaying the first and last name as it appears on your registration. The Zoom link is sent 3 days prior to the test. When you're in the Zoom format, the orientation room, during the orientation room, other candidates may be visible, but all of the exams are done in private rooms. And then you go back to a virtual waiting room for the breaks. During the breaks, you have to leave your camera on and your audio on. And you have to keep in mind that you cannot use cell phones, computers, or notes during the break. And any unscheduled break time comes out of your exam time, and that must be documented. Even though it's a virtual format, of course, you have to wear a suit or something appropriate, and make sure that it's free of any school or organizational insignias or logos, either in what you're wearing or in the background. Make sure you have a fast and reliable internet connection, of course. And as far as devices, desktop or laptop computers work, but no phones. If you use a laptop, just make sure it's plugged in the whole time. And you cannot have a dual monitor setup. In terms of do not disturb, so leave your phone in another room during the exam, because if you use your phone during the exam, they can terminate the exam itself. There's something called a room check that they do where the candidate must use their webcam and show a 360 degree of the space to show that there's no like notes or books or smartphones nearby. And they can also ask to see your desktop. So you might have to open your task manager and see what applications you have open. You have to have identification on you. So have an unexpired US or Canadian driver's license or a passport with your name matching your candidate status page. And they like that you do not use Bluetooth headphones. If you do need to use headphones, use a wired headset. We can go ahead one slide. So this is just some stuff that I went over. So be prepared for examiner pop-ups. So the Zoom exam room consists of you and 1 to 2 examiners. One of them does the talking, the other one may just be listening. And oftentimes that's someone in training who's talking and someone's watching them, vice versa. But don't be thrown off if a third person, a moderator, kind of pops in and out of the room. And so they're there to ensure quality control, make sure that things are running smoothly. So just don't get thrown off if you see that. That's normal. So the feels. I love this slide. So this exam feels very different than previous exams, and do your best to try to remain calm and just try to keep forging through. Practicing out loud and some different strategies we're going to talk about, over the next hour can help kind of make you feel more confident, prepared, because it is very awkward feeling. If you really feel stuck and you feel like you're not going to get to the other cases in the section, you can ask to skip a case, but you can't return to it, and it will count against your final score. And the interactions with examiners will vary. Personalities are very variable. So some may be more eager to kind of move you along through a case, whereas other examiners may not give you any feedback, and they might not say anything at all and just kind of listen as you try to work your way through. And in general, don't second guess case content. So you may think, oh, that's really easy, or it can't be that straightforward. Well, sometimes it is really that simple or straightforward. And sometimes the same topic may be touched upon twice. So next, we're going to go through resources and study tips. And Nora's going to take that part away here.
Thanks, Kendra. So we are going to review some of the resources that we have used and others have used, and some study tips as well. So we're obviously biased. If it wasn't clear, Kendra and I are the founders of OphthoGenie. And I'll talk about that a little bit later, but so we're a little bit, biased in what we think is the best resource, but we used some of these as well when we were studying. The one thing to remember, like Kendra touched on this, is that this is a very clinical exam. You already know everything that's on here for the most part. It's a much easier exam content wise than the written boards. There's not the kind of minutia that you had to memorize for the written board. So that is one thing that this test has going for it. But what the difficult part is the format. And as you guys know, we've never taken an exam like this, and that's what we have to prepare for. So there's different types of resources. There's books, online resources, and in person. In terms of books, Pemberton, I think, is the one that is the most used. That's the one I feel like I used the most. At the time when I was taking the exam, there was the older version of Pemberton, and they only had 60 cases in there. I know now there's a newer version and they have, I think around 120 or 130 cases. So the more cases, the better, I think. So I found that helpful. Will's Eye is, as you guys know, not an oral board prep resource, but it can be helpful to review material and differential diagnoses. And I know Kendra and I used this when we were kind of creating our study guide that ended up kind of turning into OphthoGenie. Luviano is another book of cases that you can use. Online resources, of course, we have OphthoGenie, which as of now we have 200 cases that are interactive, and the study bank, which is kind of our library of cases. Optho Questions has an oral board prep resource. From what we've seen, it's mostly videos of other people kind of giving their spiel and answering, going through a case, which, personally, I don't think that's very helpful. The hard thing again about this exam is you going through the case and kind of forcing yourself to do that, but they do have some of those videos. Eye-to-eye board review is kind of a one-on-one tutoring. Some of you may have heard of that, and I don't know they don't list their prices, so I'm not sure exactly, but I know you purchase kind of a set number of tutoring sessions. In person, Kendra touched on this. Osler has a in-person course, which we both did. And then the University of Colorado has one as well, where you can do kind of a mock oral board exam. These are helpful, but in our opinion, these are supplements to other studying. This is not the sole thing that you need to do to study. They're one-time sessions, and the Osler course is the week before the exam. So you definitely need to have more, more comprehensive studying than that. So in terms of study tips, I think, the most important things, I think if you had to, boil it down, would be to talk out loud and time yourself. I think those are the two most important things. You can't really passively study for this exam. It really has to be active learning. It's useful to kind of look over old study guides, familiar study guides that you used for, for the written boards or the OCAPs, just to refresh your knowledge base. But really it's going to have to be you going through cases and talking through the cases. That's what's going to help you the most. It's always helpful to start with your weakest subject first, just to kind of, because that's the one you're going to have to probably revisit the most. Talking out loud and timing yourself, both of those are important. Talking out loud will also, doing it over and over again will help you get the structure of the cases down. You want that to be second nature to you. The ABO wants the cases gone through in a certain way, and sometimes they will just sit there and stare at you, and you have, without any prompting, and you just have to kind of know what they want to hear next. And so that's, in OphthoGenie, we kind of have that broken down for you, but in general, it's image description, eliciting the history, the physical, differential diagnosis, workup, what you think the diagnosis is, management, and then follow-up and patient education. So that should just be very second nature to you, as once you're kind of gotten through your studying a little bit more. It's very helpful to have a study buddy, kind of, if they're an ophthalmologist, that's great, kind of testing each other. Even a non-ophthalmologist, just having somebody there that you can talk out loud to, and maybe sound like you don't know what you're talking about and not sound very confident. All of that's good practice, because you need to kind of work through all of that. One of our former users said she found it very helpful to record herself and listen back to her recordings. And she would listen to the good ones over again so that she could kind of remind herself what her answers were supposed to sound like. And she also found it helpful to kind of keep high yield stuff, kind of like flashcards on hand, just for when you have a few minutes just to review. And also looking at Google images of different diseases can be helpful, of different presentations of different diseases. Just remember that the images on the boards are notoriously not very good. So it's not gonna, it oftentimes is not just like a classic picture of something. So don't expect to only have to identify like pristine, classic presentations of things. So I'm going to talk a little bit about OphthoGenie. So Kendra and I have alluded to this, but we created an early version of OphthoGenie as a study guide for ourselves when we were studying for our exam. We didn't feel like there were enough resources out there, and a lot of the resources were out of date, or, there weren't enough cases. Like, we would get through them and we'd be like, I feel like I need more. I don't feel ready. And basically it started as a PowerPoint deck that our friends started asking us for it. And eventually enough people asked for it that we were like, oh, maybe we should do something with this, because we were getting very good feedback about it. And we wanted to create something that was more than just the content. We wanted to create something that would teach people how to work through the format of the exam, since that's what is difficult about this exam. And we wanted to help other people succeed with that. So like I'd mentioned before, right now we have 200 cases and we're always working on adding more. Each case is broken down into the 8 elements, which is how the ABO wants you to structure your response. And grading is broken down into the 3 criteria Kendra had discussed: data acquisition, diagnosis, and management. And you can take an unlimited number of tests. And you can see up here, this is kind of what your dashboard looks like, where it will show you kind of how you're doing on different topics. And I'll do, I can do a little demo for you. I'm not sure how many of you are OphthoGenie users or not, but I can show you guys a little bit of the platform if you want when we're done here. But basically our features are performance analytics. You can see how you're doing on each topic and in each grading criteria. Testing, there's 2 different modes, beginner and advanced mode. And, depending on where you are in your studies, and you can study with a single topic or paired topics, which is how the exam sets up the rooms. There's a timer feature, which is helpful, since timing is, as we mentioned, very important for passing the exam. And the study bank is basically the same cases, but presented in a different format, where you can select a specific case and read through the answers. This is helpful early on when you don't know what to study yet, and also later on if you want to return to a specific case to review. And then we have the study buddy feature, which was actually created pre-COVID, but it's more relevant now than ever since the test is administered remotely. Basically, you can invite a friend to grade you, where their screen will look like the examiner's screen, and yours will look like the examinee, where you just have the case image and the question stem. And this mimics how the actual exam is administered, and they don't have to be an OphthoGenie subscriber for them to be your examiner. All right, great. So that's the main kind of content we wanted to show you. I'm going to also just pull up I'm going to share a different screen here so you guys can see the study buddy feature. Can you guys put in the chat, or if any of you guys are not subscribers to OphthoGenie and you want to see what the program looks like, and I can show you that as well. But even though those of you who are subscribers to OphthoGenie, most people don't, a lot of people haven't used the study buddy. So I just want to show you guys that too.
And Study Buddy can be used with anyone. It doesn't have to be with a subscriber. But I mean, it is great if you can find someone who's taking the test in the same year or the same time as you to study with each other, because it adds, you can learn from each other when you're grading and when you're speaking. I think it's equally helpful either way. You need to speak, but also hearing other people present, you can kind of take tips from them and so forth. So. All
right, let me just start this and
how you did
screen
on that test. And if you want to go back in and view more details.
And let's see. All right. Sorry, here, just 1 second. Let me go
Also, if
in.
you guys have like any questions, like general questions, specific questions, you can type them in the chat. Oh, okay, great.
Yeah, I
we-
just wanted to show you quickly. This is, ignore the picture of me down at the bottom. This is just a video I made, but so this is basically a side by side of, I'm trying to show you what your screen would look like versus your study buddy. So on the left is what your screen would look like. So you see the question stem at the top and then the image, the case image, and that's basically what you see on the exam. That's all you're going to get. And then on the right, this is what your examiner sees. So they have the answers on the right. And then as you walk through the case, they can check whether or not you answered correctly. And that will go towards your stats. And let me see here. Yes. Okay. So let me pull up a demo for you guys. Give me 1 second here. And then we also, actually, while I'm doing this, we had some questions that people had submitted in advance, so we can go over those. So Kendra, the first question was, any advice for second-time test takers?
Yeah, I mean, I think that trying to figure out what, kind of just doing some self-reflection and trying to figure out maybe what you could have done better. I know it's hard because you don't get any feedback really. I think one of the major pitfalls that people make is that they know all of the information, but they can't convey it concisely and in a timely fashion. And so if you find that you took the test the first time, you didn't pass, and you think that you didn't speak out loud, I really can't stress enough just speaking out loud and timing yourself, how important it is. Trying to figure out if there's areas, it's nice because, with OphthoGenie, you can actually take tests and identify either by topic or, as we were saying, also broken down by data acquisition, diagnosis, and management. You can see like where you're weak. So, you're maybe really good at retina, like Nora and I, but then you weren't doing so hot in optics. And so you can kind of use that feedback to guide your study the second time around. So I think that, second time test takers would be very motivated, and you already have kind of an amped up level of anxiety. So just kind of taking a step back, seeing what topic areas you might be weak in, or what kind of parts of the question in those 3 different categories you might be weak in is helpful. And just timing yourself and talking out loud early and doing it frequently.
Yeah, I agree. I think it's first thing you want to do is look and see how you studied and try to think if there's ways that you could improve on that. What resources did you use? How much time did you commit to it? I mean, I know some people who started studying like the week before and they thought that was enough. And, and you just want to make sure that you're doing the most that you can to set yourself up for success. But again, I think the most important things is the talking out loud and timing yourself and just doing that over and over again.
Yeah. And I think, it's a very different test, like we were saying. So they're not going to ask really obscure, at least I don't think they would ask, but they didn't for us ask anything obscure. It's very clinically relevant, and anything that is potentially vision threatening or life threatening is a high yield topic. And there's, different topics you'll see as you go through whatever sources you use. The more cases you see, the more you see the patterns. Like, okay, they're going to ask something about, a corneal ulcer. And so I should know a differential for like a ring infiltrate, or there's a white reflex. I need to know the differential and the workup for a white reflex. And you'll find those kind of topics, those big topics in each topic area that you really want to know. Okay, bam, bam, bam. And you want to just be able to just kind of rattle it off without wasting any time.
So yeah, we have some other questions here that people have submitted. I'm going to do a quick demo first, and then we'll get to those questions. So this is basically what the dashboard looks like when you log into your OphthoGenie account. There's bars here because I've kind of taken some sample tests. So this is what your performance metrics look like. So you can see on the bottom, there's the 6 topics, and then the different colors are the 3 different categories that you're graded on: data acquisition, diagnosis, and management, and then the average. So you can kind of get a sense of what you need to work on. The image below is basically the same information in a tabular form. And then you can also see past tests you've taken. And there you can also favorite some cases if you want to highlight those and return to them. And then I'll just show you what it looks like to generate a test. So you go up here, start testing, and then you can choose beginner mode or advanced mode. Beginner mode is not timed, and there are prompts to help you know which part of the case you're supposed to be discussing. And then advanced is timed and without prompts. So this, as the name suggests, should be done kind of later on in your studying. There's the 6 different topics, and you can either take them as a single topic if you just want to focus on one topic for that session, or you can take them as a paired topic, which is basically simulating the exam rooms where the topics are paired into these 3 pairs. And then you select, so I'll just select, we'll select beginner mode. Let's do, we can do retina just because we like that. And then we can do however many cases for single, 2, 4, or 7, and then paired, you can go up to 14, which is what the exam would be, 14 cases in a room. And then here you can have the option to enable the study buddy feature if you want, and then your buddy would get a link for their screen. And then let's begin testing. So you can see, because this is beginner mode, you get the prompts on the right. This is in advanced mode, you don't see that. And on the exam, you don't see that. And there's no timer here because we're in beginner mode. So you can see there's the question stem at the top: 65-year-old male presents with painless vision loss in the left eye, and then your image. And then on the right here, it gives you the prompt, looking at this color fundus photograph, my attention is drawn to. And then this is blank because it's meant to force you to speak out loud and say what you think the answer is before you click reveal answer. And then once they reveal it, you can say whether or not you got it right. This is, a little subjective. There's no real objective way to make this grading. So usually what we tell people is, if you feel like you got the gist of it, like most of the important things, and give yourself credit, because that's what they would do on the exam. Like if you left out macular edema, like that's okay. Give yourself credit for that. Like you got the gist of it. And then I would take a complete history focusing on, and then, you want to talk out loud. Like, would I ask them if they have high blood pressure? Ask, like whatever your medical history is that you're going to ask, symptoms, things like that. Again, passive learning does not work for this. You really have to force yourself to say these things out loud. So basically you work through the case, you go through your differential, your workup. And again, this is very thorough. When we made these cases, you don't have to get every single one of these right to pass this case or to give yourself credit for it, on OphthoGenie. So again, if you feel like you got the majority of the things, then, and the important things, again, as Kendra mentioned, they really like to focus on life-threatening things. So, if you had like a bilateral disc edema and you didn't check their blood pressure, like that's, I don't give yourself credit for that, because they may have been in hypertensive emergency and you may have, they may stroke out. So you need to make sure that, the high yield stuff is the vision threatening and life threatening stuff. So basically I'm going to just work through this so you guys can just see what this looks like.
Yeah, and we definitely, we tried to put in all the cases, all of the different you can see it's very extensive because we wanted to really put in, this is the perfect, if you could say everything, you're not going to be able to say everything in that time, but we tried to highlight the really most salient features of cases, or if there's something kind of pathognomonic for it, or kind of buzzwords, we tried to add those in as well.
And then let's see. So I'm just going to move on to the next case. I think my internet is slow. I think my husband's on his PlayStation, so that's
Yeah,
not.
that was in the recommendations too on the ABO website, not to have anyone else using the internet or streaming, right?
Yeah, I
But
think.
once you get used to, so honestly, like using this framework is already a leg up, because you have that, just saying you'll memorize those question stems. And so just even saying that will get you through to speak, because a lot of it is just saying the getting started and saying, okay, what's next, and not just kind of blanking out. And so if you can even say like, my differential diagnosis would be, or looking at this picture, it kind of moves you along, answering the test question anyway. So the framework is very helpful in and of itself.
And then I just wanted to show you guys the study bank, because we also get a lot of questions about this. The study bank is the same cases that are in the testing feature. It just allows you to actually click through them and pick whatever one you want to review. So let's say you're starting out and you're just like, I need to review some neuro-op stuff. And okay, so I just want to read through a case just so I know what I'm, just so I can get the material in my head. So you can actually just kind of go through and do reveal all elements, and then you can kind of just read through the case. So this is helpful early on when you're studying, or towards the end of your studying when you're just like, oh, I'm so bad at congenital esotropia, I just want to review that one case. So that's kind of where that is helpful.
Also the favorites, I was just going to say, you can also favorite the cases. So sometimes, like, if you're always forgetting, the differential of, like, I don't know, fourth nerve palsy or something like that, you can favorite it and then review that right before the test, make sure it's fresh in your mind.
Yep, and that's with the star up here that you favorite a case. Okay, good. So I'll just go through some of the other questions we have. If anybody wants to see something specific, a demo of something specific, just write it in the chat. But so one of the questions actually, let me pull it up here. So do examiners ask for explanations of ophthalmic principles that would extend beyond data acquisition, diagnosis, and management? For example, OphthoGenie's case on asteroid hyalosis asks for describing coma and reflectivity as well as optical interference. Will similar questions be asked on the actual boards, or is this intended to provide a greater depth of knowledge while studying? So that's a good question. So the asteroid case that we have is in our optics section. So I would say if it's in the optics room, then they can ask you stuff like that. They tend to like, with optics, they tend to like to have a clinical relevance. So, they're not going to ask you out of nowhere. Like if you're in the retina room and you order a fluorescein, they're not going to be like, what wavelength is the the fluorescein molecule emit? And so it's not like that. They want more, they like having clinical like correlation or importance of the optics information they're trying to get you to demonstrate that So, but if you're in the optics room, yes, they can ask you those kinds of cases or questions to demonstrate that those optical principles, but they're not going to do that in the other rooms. The optics questions tend to have a little bit different structure than the standard 8 elements that we've been discussing. And I felt like for the optics rooms, it was kind of, from what I remember, more just like, oh, this person is complaining of this, or they had cataract surgery and they're, you know, they're noticing this, and it's not quite the same, like, you know,
Yeah,
you can still use some
differential.
of what you've
Yeah.
learned into like, oh, I would ask them this and I would check for this and this is what it might be, but it's a little bit different in the optics rooms, but they do like to kind of combine. I remember there being overlap with like the anterior segment and optics cases where I was like, it wasn't clearly one or the other, it was kind
Right.
of a mix of both. Do you have anything
And
to add to that, Kendra?
yeah, no, it's very clinically based. I would say they're not going to ask you to draw out those like, you know, vector diagrams. Oh God, I hope not anyway. And you know, or like you're stranded on an island and you have to use a lens to catch a fish, or I don't know. It's nothing like that, but it's like, oh, this person had cataract surgery and like they had a hyperopic surprise or what have you, like what might have happened, or this person comes back with their glasses for the third time and they're unhappy because they said that X, Y, and Z. What can you do? You know, and then I remember that was like one of the questions was something like that. Someone said happy with their glasses. And you're like, okay, so, and that's all the information they give you. So then you have to say, okay, I would ask them, you know, what are they having double vision? Are they, you know, whatever. And, you know, they're trying to get to, you know, this optics principle. And so you kind of go through the conversation that way. So it's clinically based, but but they're trying to test your knowledge of the underlying like optics principles and how it relates to like anterior segment, cataract surgery, and that kind of thing, if that makes sense.
All right, some other questions we have. One question here we got in the chat was for the pictures where it's obvious what it is, like a horseshoe tear or capillary hemangioma, should you still try to list a differential with several different other diagnoses, or spend less time on that and go straight to the management? Or are the boards hard enough where there aren't really ones where it's extremely obvious? So those are all good questions. So I would say there are some where it will be extremely obvious. Don't second guess yourself if you feel like it's obvious. It's not there. I think for me, there were maybe like one or two where I was like, I have no idea what that is. And one of them was retina, and I'm medical retina, and I was like stumped. So, I mean, that's not.
Sometimes it's just a bad picture and you're like, I really just like can't figure out what they're trying to show me in this, you know?
Right. So even if it's obvious, you should still list a differential. And that's why it's also good to just learn the differentials of certain things. Like, even though for you, if it's obvious that it's like a capillary hemangioma, you know, you should kind of know the differential of other vascular retinal lesions or tumors and just kind of list those, even though you know that's not what it is. And then when you get to your diagnosis, you know, then you say, this is what I think it is. So you should still have a differential, because they still want to know that you know what else it could be, or what else to kind of think about.
And you can list them, like you could say like highest on my differential is this, but I, you know, would also consider blah, blah, blah. Or if it's something, another important thing I think would be like, if it's something that probably like it's, I don't know, I'm trying to think of an example, like a sty or chalazion, like something simple like that. Like, this is most likely a chalazion, but I'd, you know, would want to make sure it's not a orbital cellulitis or preseptal cellulitis, something like that. Like, you want to make sure on your differential that you're excluding like vision threatening things. Giant cell arteritis, for example. You should always be thinking about giant cell arteritis, things like that.
Yeah, I think that's good advice. One other question we got was tips for the optics session. I guess we kind of talked about that a little bit, about mostly like the clinically focus kind of on clinically relevant concepts. And then someone else asked if we could go over a review of study plans, specifically in what order different resources were used. I feel like for me, I don't know if it was so much the order of the resources, although we did kind of touch on how the those kind of mock exams or Osler, or those things should be kind of later on once you've already done a lot of your studying. But I would say the way I structured it was initially kind of just reviewing content. Like I went through wills and went through some of my old notes, and just to kind of refresh all of my memory, because it had been a while since I thought about peds, things like that. And then started testing myself without a timer, just like take as long as I want and just try to get through a case. And then I started, testing myself with a timer, and then I would have a study buddy test me, and then I did the Osler course. So I kind of would do it where you kind of work up slowly in kind of difficulty in terms of and this is all as most of what I just said was all about the learning the structure, right? Like the content was like the very first step of my studying. Most of my time studying was trying to just go through the cases over and over again, and each time making it a little bit closer to what the actual exam is like, and a little bit harder each time. So I went through Pemberton multiple times. So you want to just the repetition and just forcing yourself to make it as exam like as possible with the timer and talking out loud without any prompts.
I think that's something for me. Like Nora and I, we honestly like created something unique. So, I mean, that was a little different for us. We had 500 and we're still working on we have more cases to add to OphthoGenie, and we're working on it. We're always putting on new cases. We have like 500 slides in our slide deck because we're crazy. But I jumped right in because I had a study partner who was also taking it. And we just like met up one day, and he pulled out his phone and was like, okay, showed me a picture and just held it up, and was like, go. And it was wildly like anxiety provoking and awkward. And I didn't want to start that way. Like my comfort zone was like, I wanted to just keep reading cases, and I wanted to just like read them like I used to and maybe quiz myself. But I'm so glad he did that, like forced me to do that, because I realized immediately like, oh, my issue is not going to be like knowing it or not. It's going to be conveying the information. And so that made me like hyper focused early on to like just nail down that format. Like you do this, hit all the points, like describe the picture, do the exam, do the differential. And I think that's what really helped me become very efficient.
All right, we got a few other questions here in the chat. So somebody wrote, I heard conflicting info. I'm comprehensive ophtho. Let's say a question is about something retina or strab. For management, should I say I would do a lateral rectus recession, or I would do a PPV with silicone oil, or I would check patient for endocrine labs, or should I say I would refer to retina, I would refer to peds, or I would refer to endocrinology? So that's a good question. So they want you to act as pretty much everything, except for non-ophthalmology fields, like non-ophthalmology or optometric fields, where they want you to say that you would work with
or something.
You would work with their endocrinologist, or work with their oncologist, or kind of, they don't want you to defer to another specialty completely. So if it's peds, they don't know what specialty you are or care. They want kind of expect everyone to answer, they have the same expectations of everyone, no matter what your specialty is. So if it's peds and they need strap surgery, you say, I would do, even if you don't do it in real life and you don't know how to do it in real life. I don't remember how to do that, but you still, when you're doing the exam, you say, I would do a lateral rectus recession, or I would do, or I would check them, I would work with their PCP and check their TSH and free T4, or I would work with their oncology. I'm worried that this is choroidal melanoma. I think they need a metastatic workup. I would work with their oncologist and look for, do a liver ultrasound and LFTs. And like, they want you to know that stuff too. They don't want you to just defer. Even low vision stuff, I remember someone told me like they expect you to be like the low vision optometrist too. So so yeah, I would say assume that you are responsible, but if it's not within ophthalmology, just say you would work with their oncologist or whatever other specialty that you're involving. Kendra, do you have any other thoughts?
Yeah, no, exactly. I mean, yeah, you're it. Like, even though you don't do those things, that's what they're testing. It's with anything within this scope of like a comprehensive ophthalmologist. But I know like even they ask questions like if you do
Even more than
vitrectomy
that.
surgery,
Yeah.
you know, you have to know that like cataract's a complication. So you really have to know anything that's in those like basic science review books, the BCSC, like it's all fair game. Even though you wouldn't do that in real life, you would talk about putting in the tube, doing a trab, what you'd look out for, all that kind of stuff, as if it's you doing it.
You should think of it as like old school ophthalmology, like 50 years ago, you're practicing in the middle of nowhere in like Montana. Like you're it, like you're not referring to anyone else. All right, couple other questions
You have
here.
some questions, I think, in to you, and then there's a couple in the general chat. I think there's, because I
Yeah, and
can't
then
see the ones that you're talking about.
Oh, okay. And then if you have any that are direct to you, you can read those as well. So Tim asked, is the exam conversational? Will they provide you with information as you're going through the case, or are the examiners just listening to you speak? So that varies depending on the examiner. I had some examiners where I started my spiel and I was just kind of like on a roll, and they kept interrupting me to like move me along, or like I think sometimes they like know you know what you're talking about, so they try to kind of get you through the case. So just follow their lead. And then I had ones that like sometimes they will offer more information. Like if you say, this person's coming in with like complaints of loss of peripheral vision, and I say I want to get a visual field, then they might then show me the visual field next. So there are times that they give you additional information. And on OphthoGenie, some of our cases, you'll see that where it will say like additional information will be provided. And then once you ask for it, like a field or an MRI or a fluorescein or something, they may show it to you, but they may not. And then depending on the examiner's style, they may try to help you or try to move you along or speed things up and just go with it. Or I've had ones that have just sat there and stared at me. And then when once I finished, they would just say anything else. And I'd be like, and about what, so sometimes they really don't give you much. So it really varies, and you have to be prepared for any of it.
Yeah, agree. I would second all of that. So some people, I think that if you're veering off course, they'll try to kind of redirect you, or if you're leaving out something, they might ask, what else? Is there anything else? Which is kind of stressful when you're like, I don't know, I would have said it if I could think of anything else. But then I had a couple that just said nothing and let me kind of go through. But I think they do try to kind of keep you aware of the time, but I wouldn't rely on that. I wouldn't rely on them to move you through the case.
Right. All right, next question. Do you have any comments on Friedman's? Is it any different from Pemberton's or just more cases? I think from what I remember, I think I used it and I felt like the cases I still used it, but I feel like they were way more detailed than the actual exam. And I remember being like, there's no way I have to know this, or, I think I just used it kind of as like just more material, that's my recollection of it. Kendra, do you have any?
Yeah, I can't even really remember it being, was that the case reviews one? I'm not sure which one.
They had one for the like
Oral
written
board.
words, and then they had the cases. Yeah.
I don't remember it being, I know that I looked at all of them. Yeah. I mean, I looked through basically all of them. I tried to find actually the crossover more because I wanted to look at all of the books and try to figure out like what were in each like, and we did this when we were making OphthoGenie, basically, like look at all of the books and then figure out like what are the important topics that they really are consistently highlighting in all of these books. And I don't think that any of the books are greatly different according to like the information they're giving you, but it's helpful to see like the different case topics because there's a lot of overlap. And so if you see a lot of overlap, then you should probably know that case like in and out.
Yeah, I agree. All right, how much in detail do I have to go in when stating the management? For example, if it's a retinal detachment, do I have to say PPV, sclerobuckle, and silicone oil, so on? I think you probably do need to go into some detail. You probably should know like what types of retinal detachments are candidates for pneumatics, or, you know, maybe like a younger person that you were worried about them getting a cataract after a vitrectomy, or I would know some,
Yeah.
and you can also kind of, they just want to know that you know some of this stuff. So when you're answering your question, you could say, you know, like, oh, there's a bunch of lattice and tears everywhere, and this is a young person, or, you know, then I would maybe consider doing a buckle, or this is like a redetachment, and maybe I would do silicone oil. Or I think I don't know if you have to like be 100% sure of what the right answer is, but if you kind of reason through the logic behind some of it, I don't think you can just say like it's a retinal detachment and it needs a surgical repair. Yeah.
Yeah. And if that's enough, then fine, then they might just go on, but they might also, part of that, like when I was going through that, the counseling part, like the management part is education. And if you are going to do surgery, I think you should know the risks and benefits of the surgery. So I think that is definitely fair game. I think Nora got asked a question like that. You know, so I would say within reason, you should know that. I don't think they're going to ask you like, well, would you use C3F8 or SF6? You know, I mean, there's certain things that I think it's beyond the scope, but you should have an idea of why you might choose one over the other for a particular patient.
Mm-hmm. All right, and one other question. Will they give descriptions of an MRI, or will they show you a picture and expect you to be a radiologist? I think they can do both. I'm trying to remember.
Yeah, I think if it's like I'm trying to remember too, like if I specifically, I think usually like the imaging was more in terms of, I mean, they really could though give you imaging questions and say there's certain classic things you should be aware of. You know, if you have like an enlarged superior ophthalmic vein, if you have like a tram track sign, it's meningioma,
pituitary mass, like there's probably,
yeah, like I think you could, I think they, I mean, you don't have to be a radiologist. I don't think you have to be, you know, super in detail, but you know, I don't think you need to know all of it. But again, we're just saying what we think too. We're not examiners, but I would be prepared to at least be able to tell if there's like an orbital fracture, or you know, in the setting of trauma, to be able to kind of read those kinds of things, or other kind of classic signs that are reasonable for an ophthalmologist to know.
or if you have like an orbital or preseptal cellulitis, like they might show you a CAT scan and expect you to say if there's sinus disease or not. Or so I think I don't think it's going to be super subtle, but I think they can show you you know, neuroimaging and expect you to have some interpretation of it.
And you can go through the I know some people, I didn't do this because I just didn't have enough time. By the end of it, it's kind of, there's so much information, but some people went through just the images in the BCSC to kind of get in their head, like, and they do, I mean, I believe they had some imaging and stuff like that in there just to kind of get an idea. Like, I didn't see path slides. I don't think there's path slides or anything like that, but you know, just to kind of keep in the top of your mind, like different things. If they pull up a scan and show it to you, then definitely look into it. They're showing it for a reason.
Yeah, they're probably not going to show you a normal MRI, I would guess, but. All right, so it's about 7. Any last minute question, or sorry, 7 Mountain Time. I don't know where all you are, but it's been an hour. So if there's any last minute questions, feel free to drop them in the chat. We can hang out for a few minutes, but thank you everybody for attending, and feel free to email us if you have any questions. You can email support@ophtogenie.com and it'll get to us. So
Yeah, good luck, guys.
yeah, good luck.
Gonna do great. Thanks.